Hi, good morning. I think we'll get started here. Thank you all for coming. Thank you for taking time to learn about a topic that interests me a lot: shoulder arthritis, chronic shoulder pain, and rotator cuff injuries. If you have any questions along the way, please feel free to stop me at any time. The shoulder is the third most painful joint in the body, behind the knee and the low back. Symptoms of shoulder pain include chronic pain, compromised function within the shoulder, and mostly a combination of these, both pain and difficulty with motion. This often results in a lot of difficulty with sleeping and with activities, especially overhead. Just a brief look at the anatomy of the shoulder. Here we have the ball and the socket. The ball is really the top of the humerus, which is the arm, the upper arm bone. And then we have the shoulder blade, the scapula here, which is really in the back. The glenoid here, which is the socket, articulates with the humeral head here. In addition, in the shoulder, we have the clavicle, which is the collarbone, and a piece of the acromion, which is part of the scapula or the shoulder blade. So these are examples of what shoulder arthritis may look like. Here you can see there's a shoulder with a normal shoulder joint and a nice space on the x-ray. And you can see here there's really no space at all. We know that shoulder arthritis is the third most common type of joint replacement currently in the US. This follows, of course, hip and knee replacements, but about 50,000 are done every year. We know that there have been really good studies to show that the results of shoulder replacements are just as good as hip and knee replacements. We know that many patients, 95% of patients, have reported pain relief after shoulder replacement operation. And so I think you can hang your hat and say that shoulder operations do well. You just have to have the right patient for it. When we talk about shoulder replacements, there are really three types of shoulder replacements to talk about. There's the standard shoulder replacement, which would be replacing the ball and the socket. There's a reverse shoulder replacement. That's a variation of that replacement, and we'll talk about that further. And then there's the shoulder resurfacing, which is just replacing a part of the shoulder. Shoulder resurfacing is where we replace just the humeral head. So we talked about the humeral head being the ball portion of the ball and socket joint. This is an example here, a schematic where the ball is just replaced with a small piece of metal here. This really doesn't take the ball off, it just covers the surface. So this would be for someone that maybe has a small amount of arthritis in a small section, maybe someone that's younger, that's not really a candidate for a total shoulder replacement because they will end up doing a lot of wear of their shoulder. It's exactly right over the shoulder, so it's just a very smooth taking off of the cartilage at the top of the shoulder and then replacing it with a metal ball.
How is the arthritis determined, from an X-ray or an MRI?
It's a combination. So an MRI is helpful because it can tell us some extra detail, but a lot of times, for example, in this image here where you can see some bone spurs down here, you won't see that in an MRI well, and so an X-ray can help for that. So I think a combination of the two images is helpful. So I should stress that shoulder resurfacing is a better option for someone that has no arthritis on the socket portion, the glenoid portion. Most people that have shoulder arthritis have arthritis on both sides. And so if you were to do a resurfacing and you had arthritis on the glenoid side, you're not addressing that, and you're probably looking at another operation in the future. So really this operation is dedicated for someone that's very young, that you don't want to take a lot of bone doing extensive operation. It's sort of a staging operation of sorts at this point in time with the technology that we have.
What's the material you use? Is it plastic or metal?
For this one, it would be a cobalt chrome material, so metal material. Shoulder replacements, we talked about standard shoulder replacement and reverse shoulder replacement. We'll speak first about total shoulder replacement. This is where you replace the ball and the socket of the shoulder joint. So here you can see again there's a ball that's replaced here, but in addition you'll see a plastic piece here on the metal which articulates here. This would be a polyethylene piece and this would be a cobalt chrome piece. In addition, it's then seated into the humerus here with a piece of metal which would be stainless steel. Reverse shoulder replacements are an interesting newer thing in technology, maybe in the last 15 or so years in the US and maybe a little longer in Europe. There's a lot of research on this now and people do very well with it. Shoulder replacements are done for shoulder arthritis. Reverse shoulder replacements are done for people with arthritis who also have rotator cuff issues, meaning that their rotator cuff is no longer working. A total shoulder replacement works very well for someone that has an intact rotator cuff and is able to use those muscles to move. If you aren't able to use those muscles, then a reverse shoulder replacement changes the configuration, meaning that the ball goes on the socket side and the socket goes on the ball side. creating a different force dynamic, which allows you to use the shoulder for elevation and rotation, even without an intact rotator cuff.
So that means if with my rotator cuffs, I have a hard time lifting, say, a book on a bookshelf or something like that.
Mhm.
This would be a possible solution to that.
Exactly. So if you had a rotator cuff tear and shoulder pain and arthritis, this would be a really good option. And this,
I'm not ready for that yet, but.
okay. And these can also be used in other patients. So say, for example, someone that has a very bad fracture that you're unable to repair because the pieces are just too small and the quality is not good, this would be a really good option for that. This could be a really good option for someone that doesn't have arthritis but has shoulder pain and inability to raise the arm, like unable to raise the arm more than, say, this far, 30, 40 degrees up. This could be a really good option to get them to raise their arm overhead, maybe up to here or even a little higher. And it can really be a really good pain relief operation for a lot of people that have a lot of debilitating shoulder pain. So I think it's been very, very revolutionary in shoulder treatment. Like we talked about, shoulder replacement through reverse shoulder arthroplasty is really best for patients that have some sort of compromise with their rotator cuff. These are people that often have a long-standing rotator cuff issue.
So you actually use different muscles with a reverse.
Right. So use the exact same components. In fact, the same companies make the same implants. In fact, we often have both sets of implants in the room at the time of surgery. Yeah, the same ones that are back there. We have both available at the same time because if you had a fine rotator cuff, we may then say, well, let's just use the total shoulder. It's better for that case. If we see that the rotator cuff isn't working well or we were expecting it was and it wasn't, then we go to the reverse. So it's really interchangeable. It's just what you need at that time. So these are some of the components, and there's some nice examples in the back that we have sitting around if you want to take a look. This is an example of a total shoulder replacement. So we can see there's a ball here, the stem that goes down. This is the component, the polyethylene plastic component that goes in the glenoid or the socket. This is an example of a reverse shoulder replacement. So you can see the ball is reversed. It's up here into the socket, and the stem goes down here, which would be the socket portion on the humeral head. This is an example of a resurfacing, which we saw at the first image. So what are things you should think about when you're talking about shoulder replacements or if you're considering a shoulder replacement? We know that about 75% of shoulder replacements are done by general orthopedic surgeons that do about a case to 2 cases a year. We know that their research shows that the more volume someone does, the better the outcomes.
Yep.
What are things that you should think about when you are looking at shoulder surgery? You should, one, think, am I a good candidate for this surgery? Are you a good candidate for surgery in general? Surgery comes with risks, so we have to think about those things. Are there any interactions with your current medication? Are you taking blood thinners? Are you taking medications that may reduce the amount of bone healing? Are you taking medications that may reduce your quality of healing at the skin level? We should talk about those things and maybe discuss those with your primary care doctor before you decide to move forward with surgery. What kind of help will you need after the operation? Will you need to stay with someone for a few weeks? You will be wearing an arm sling and unable to use that arm for a few weeks at least. So what kind of help would you want around the house at that time? How long is the recovery period? We'll talk about this. It's usually several months to get full recovery, but recovery for daily living activities is rather quick. Will you have pain? I think this hospital and a lot of hospitals are very good at controlling pain. Oftentimes surgery is done with a regional anesthesia in addition to a general anesthesia, so you have the arm which will be completely numb after the operation for a period of time. You'll also be fully asleep for the operation. Post-operatively, we use cocktails where we inject medication around the joint so that the joint is feeling less inflamed than it would otherwise. You go home with a nice regimen of medication. And so most patients that I have that have shoulder replacements have very little pain. They maybe have pain just a normal amount after surgery, but not enough pain to say, I had a joint replacement. When can you return to your daily activities and hobbies? I think those work through with time, generally about several months until you get back to exactly what you want to do. What outcomes can you expect? Outcomes for shoulder replacement are really pain relief outcomes. So we're hoping that with this operation, we can reduce the amount of pain. You're able to sleep on that side, you're able to lift light things, you're able to reach overhead, you're able to do activities around your house. A lot of people get full motion above head with shoulder replacements. With reverse shoulder replacements, the average motion is about 120 degrees, meaning you can get up to here, which is enough to get to your head, to get to any cavity you want overhead, and to get around and do most things you want to do in your life. Of course, if you were, say, an avid over-the-head athlete, this wouldn't be a good operation for you, but we'd then have other options for you if that were the case.
Is that just a function of the mechanical device that you can't get?
It mainly for the shoulder, reverse shoulder replacement is a mechanism of the mechanics of the device.
Doesn't matter, it's limited by the range of the mechanical device.
Yeah, and when I say the average is 120 degrees, there are people that get 170 degrees, which is full motion. And there's some people that get 120 degrees. And we don't know and we can't predict who gets what. And it's not because you had arthritis for 10 years versus 5 years. It's not because you're extremely flexible. It's just really no rhyme or reason. And you can put all the implants the exact same way and that happens.
And that's opposed to a regular shoulder replacement where you could get full range of motion possibly, or?
The likelihood of full range of motion is higher with regular shoulder replacement or total shoulder replacement. The total shoulder replacement doesn't change the mechanics of the joint as much, and so that's the reason for that.
But the reverse actually is better for the rotator cuff impairment.
Right, so if you had a rotator cuff issue, then you wouldn't be a candidate for a total shoulder replacement. But I do believe, and I strongly believe this, that a lot of people that have shoulder arthritis have a lot of shoulder pain. They're unable to sleep, they're unhappy, they can't do simple things like lifting a 5-pound object. And so even to get relief to do that, plus to get overhead and do things, is a huge benefit. And so I think it can't be understated. What sort of long-term restrictions do you have? With shoulder replacements, there are really no long-term restrictions. If you were much younger, we would say there's a concern that the plastic may wear out with time, but the plastic is very good. The lifespan of these things is at least 15 to 20 years with no problem in the hips and knees. And we know that the shoulders are non-weight-bearing joints. You don't walk on your shoulders. So the life likelihood of these implants is probably going to outlast anything that we would ever think about. So as a surgeon, what do I think about? What's your age? What's your activity level? What's your overall health? You know, this is not a small operation like an arthroscopy. You do have to make an incision, so we want to make sure that you are optimized for that. We want to know what the conditions of the muscles around the shoulder are. Is the shoulder able to recover? Are you able to use the muscles around there once you have the operation to utilize the implant that we've put in? What's the quality of the bone? If you have severe osteoporosis, are we concerned that the bone may not heal around the implant? That may be a concern of ours. Luckily, there are different options for that, and so we can really do it on almost anybody, regardless of bone quality. We just have to think of that ahead of time so we're prepared in going in and knowing what to do. Are you able to perform rehab after surgery? So rehab is the most important part after surgery. With a great shoulder replacement, but poor rehab, the results will be horrible. And so we really have to be dedicated to the rehab, and it has to be a couple times a week for a couple months, and it has to be at home for the other days a week when you're not in rehab. And without that, no matter what you do, the shoulder won't do well.
You've got to get the weight bearing to get the bone to build back up again, I guess.
Yeah, and you don't want to become stiff. So the most common complication with shoulder replacements is stiffness, because
I mean, when I had shoulder surgery the second time, I came out and he said, lift your shoulder. He said, get out of here. You don't need physical therapy.
yeah, so you were lucky. A lot of people have a lot of pain and are unable to lift it, and over time it becomes stiff, and then to get through the stiffness is very difficult. And so we want to just make sure that we get into rehab right away. And so I start, and I'm sure other people start rehabilitation within a few days with a therapist who's watching you very carefully, making sure that we're progressing week to week to week. And then the last question, what about arthritis? So there are different types of arthritis in the shoulder, and we address those slightly differently. We also talk about the severity of arthritis, because as arthritis progresses, there's bone erosion and other things, and so we talk about that, and it may determine what type of implant we use and what type of outcomes we expect. So what can you expect if you're considering shoulder replacement surgery, please? So she asked if your shoulder subluxes, what sort of options are available? And so shoulder subluxation is one step below shoulder dislocation, meaning that the shoulder feels like it's going to pop out, but it doesn't pop out. And in that scenario, there are a couple of different treatment options, partially age-based. So if you're, say, in your 30s, 40s, 50s, 60s, and you're having a lot of discomfort with certain activities, potential arthroscopic repair of the area that is causing the subluxation, where the bumper is no longer holding the socket together, is a viable option. That's something called a bank cart repair, or something you may have heard of. There, as you develop arthritis from maybe some chronic instability, meaning that the bone is now shucking back and forth over years, and maybe you've developed arthritis because of that, that would maybe fit into a shoulder replacement type scenario. And so then just based on the rotator cuff, we would know what to do.
But without having the arthritis component, wouldn't you recommend physical therapy first to strengthen the muscle rather than?
Of course. If we're talking about chronic subluxation, so that would be a surgical treatment option. If you had acute subluxation, meaning just happened a couple of times over a few weeks, then therapy is definitely the way to go.
That's an acute situation.
Right. So the surgery is done through an incision in the front of the shoulder. It's about a 3 to 4 inch incision. It goes in the front of the shoulder, right in the crease. It's actually very cosmetic. The site is prepared. Of course, we use instrumentation to look inside. We place the components in and we close. You have a dressing on this about this big, about 4 or 5 inches, which is over the 3 or 4 inch incision. Surgery takes about 2 or 3 hours to do. Recovery is generally done in the hospital overnight. Most people prefer to do that. I think it's nice to be able to utilize the pain medication in the hospital, utilize a physical therapist for a day before you leave. Oftentimes I'll do this in the afternoon or sometime after lunch, and people are out the next day before lunch. And I think that time frame is nice because you have the opportunity to ask any questions, do anything you want to do before you go home. But certainly it could be done as a 23-hour stay or even less if you chose to do that. People are most often able to return to their daily activities within 2 weeks, so just getting around the house, doing things they want to do. Often able to return to driving in about 3 weeks, depending on how you're feeling, if you're off narcotics and things like that. As we talked about, physical therapy is really the most important part of this. It's critical to your success. It has to begin early, so we like to have people do therapy the day after surgery in the hospital before they leave, and then to have therapy set up for 2 or 3 days after they leave the hospital, continuing 2 to 3 days a week after that. Home exercises are crucial as well, so they'll teach you to do some pendulum exercises, other things like that, so that you can be doing that at home when you're not with the therapist. And therapy will be done both at your home and as well as at a therapy facility. Recovery time is about 3 to 6 months for full recovery. Some people may take a little longer, some people are a little faster. Just depends on how you're feeling. So the goals of this are really to decrease pain, which I think most people with shoulder issues have a lot of shoulder pain, and so our goal is to really reduce pain. We're looking to increase mobility. We're looking to gain full mobility. If we can't, then partial mobility, maybe just a few degrees less than what you were hoping for as full. We're hoping in addition to have restful sleep, meaning that you're able to sleep on that side again. And we're hoping that you can return to daily activities. But with any surgery, there are complications to surgery. There's always a risk. These are rare complications. We don't see these often, but there is a risk of infection from a surgery. There's a risk that the components could dislocate, just like in a hip replacement. There's potential for a postoperative fracture, so if you were to fall on it or something were to happen, it could break around the implants. And there's a risk that over time things could wear, the plastic components could wear. But we know that the plastic components tend to be pretty good, and so that's a less and less important risk as we go further and further in the development of these implants. So I'd like to share with you 2 case examples before we close, and then we'll open up for some questions. I'd like to show this image, which is a normal shoulder. So here we can see the space between the ball and the socket, the glenoid and the humeral head. And then here we see a patient. This is a 51-year-old lady who came in with shoulder pain for many years. She was unable to raise her arm above about 90 degrees in forward elevation because of limitations from pain, but she had very strong rotator cuff function. She had good strength with her shoulder. It was just painful. And so here we can see both shoulders actually. This is the right and this is the left, and you can see there's really no space between the socket and the ball. And
Did you say she had strong rotator cuff function?
She did.
They were good. Rotator cuffs were okay.
Right, so on MRI as well as on exam, she had intact rotator cuff. And here we can see that there's some signs of arthritis. So you can see that the humeral head is flattened here. We can see that there's a small bone spur down here, which are often common signs of shoulder arthritis. So what we did is we did a total shoulder replacement. We knew her rotator cuff was okay. She's 51. MRI showed that it was okay. So we replaced the ball and the socket. This would be a plastic piece here and the ball with the metal piece here. And she did very well. She was able to gain about 170 degrees of motion in forward elevation and external rotation. She had some limitation with internal rotation, but she's easily able to get to her back pocket and to the middle of her back.
So when you say 100, so this is like 90 degrees?
So 180 degrees would be straight overhead, and she's just a little in front of that.
Okay, so.
And so that's what most people's normal physiologic shoulder motion is. Some people can get much further back, but then they start using their shoulder blade to tilt. So we're talking just shoulder motion itself. So this is an example that may be an interest to people that have rotator cuff issues. This is a 55-year-old female with shoulder arthritis and a massive rotator cuff tear. This is her preoperative x-ray. So generally 55 is young for this sort of operation. Generally our age requirement is 60 to 65 for reverse shoulder replacement, but she had really undergone everything and wasn't feeling that her results were acceptable, so we discussed this. We can see again here there's a small bone spur. The most important thing here is you can see, we talked about the acromion at one of the first slides, and that's up here, and you can see that there's really no space here between the ball and the acromion, so that means that the humeral head over time has just gone up, and really the rotator cuff would be on top and hold the head down. And without a rotator cuff, their head just goes up further and further. And so you can imagine, not only is there some bone-on-bone action here, but there's some bone-on-bone up here too, which limits the amount you can rotate your arm forward. So just to confirm, we had an MRI, and so we can see this MRI of her shoulder, and you can see the rotator cuff is really retracted, meaning that it's no longer at its insertion here, and it's sitting right about here somewhere. And it's actually sitting at the level of the socket here. So she had a very big rotator cuff tear. If you had to measure that, I would have guessed that would be 4 or 5 centimeters of retraction in the tear.
Now, those bone spurs you've been showing, is that fairly normal as you age that you get? Because I had impingement as well as bone spurs and had several surgeries to take care of it. Is that fairly normal in people who age or what?
So there are 2 different types of bone spurs that people talk about. There's one in the setting of a rotator cuff tear, which would be an acromial bone spur, which is when people do a test where you rotate your arm like this and maybe you feel pain here. That's a bone spur not within the shoulder joint itself, but sort of on the top of the shoulder. And for that, an arthroscopic surgery at the time of rotator cuff works well.
Within the joint itself?
The one that we're talking about, which is in this x-ray, is really a bone spur here, which is in the shoulder joint itself. So that's part of the ball that is moving on the socket.
So that would impinge on your moving the joint?
It would. So at certain motions, it's just a bone-on-bone block. And so no matter how much you did therapy or how much you pushed through it, you just couldn't get through it. There's nothing you can do. And so here we see that it's up here, and then it's also a smaller space here. So we did what's called a reverse shoulder replacement here, which we talked about. And here you see there's a ball structure on the socket, and the socket is down here. You can't see, but there's a piece of plastic in between here that's not shown on the x-ray. And so with this, she gained about 130 degrees of forward elevation, meaning a little bit further than 90, which would be straight out.
Yeah.
She got about 30 degrees of external rotation, which is about here, and she was able to get to her back pocket without pain. And so I think for people like this, really the most important thing is that those motions were pain-free.
Is there a device in development for the reverse that you can get a larger range? Because right now I have horrible rotator cuff tears and pain, but I have full range of motion. I just don't have the strength.
So I think there are a lot of people that are working on developing better reverse shoulder replacements, but reverse shoulder replacements have some issues with the mechanics, and so I think we're sort of limited by that at this point in time. Of course, everyone's different, like we talked about. Some people get full motion with reverse shoulder replacements, and some people don't, but they still get some people get full motion, but some people don't get full motion. And so there are patients that get full motion with shoulder replacements that are reverses.
Can you differentiate why that is? I mean, is there any sense of
It's,
in the patient itself or the...
you know, you would think that it's because maybe their muscles are tight or because their shoulder arthritis has been for a long time, but you can't really tell. There's no 1 or 2 things we can say will cause that to happen.
You described the full and the reverse, but that is the actual sequence in the operation and recovery. But what about just the cap for an arthritic?
For just the ball, basically. So that's something akin to a shoulder resurfacing where we would just clean the cartilage and place a metal ball on top of that. So that can be options for some people.
And what is the same incision, the same recovery, the same?
The recovery, the incision are all the same because we have to get to the same spot. We have to go through the same muscle, and so the recovery is generally the same, maybe a little bit faster, but about the same.